So, hello everyone, this is Dr. Aliyah Baluch. I'm going to be talking about sepsis and specific case scenarios. This lecture was originally put together with data up through January 2015. So, as a cute joke, gratis of one of my fellows, just when you look at data, looking at p-values and making sure you're looking at good data. So the goals and objectives today is to review the nomenclature, review the Surviving Sepsis Campaign, discuss implications of updated publications, and go over a couple scenarios. So as an introductory case, Mr. Adam is a 31-year-old gentleman with past medical history significant for acute myelogenous leukemia, status post a match related donor allogenic stem cell transplant approximately a year ago. In terms of his chemotherapy regimen during his transplant, he got fludarabine, busulfan, and what we call a MAC regimen. His immunosuppression was sirolimus and tacrolimus, but because he was doing well, the primary team is in process of weaning off the tacrolimus. In terms of his antimicrobials, he's on prophylactic acyclovir. Other pertinent past medical history for the case was that he has a history of CMV reactivation, status post ganciclovir, transition to valganciclovir during his initial 100 days post-transplant. He also has a history of acute GVHD, approximately 60 days post-transplant that had resolved. He currently has no stigmata of chronic GVHD and not on any recent prednisone. Social history and family history were non-contributable. He comes with a complaint of difficulty in breathing, cough, sputum, fevers for 48 hours. He has increasing fatigue. When asked, there were no obvious sick contacts at home, but he has resumed his work as an engineer, so he is out and about. In terms of pertinent physical exam, his vitals, he's febrile at 102 degrees, he's tachycardic at 120s, respiration rate 22, BP is 100s over 50s. The key thing is when you look at him, you can tell he looks sick. So when you look at this, you're like, what about your first thought differential diagnosis? And you're like, he has a whole bunch of respiratory symptoms and he's febrile. So does he have an upper respiratory infection versus a lower respiratory infection? Viral or bacterial? Way more than fungal. Pneumonia with bacteremia only. If he does have a significant respiratory infection like influenza, you can have an increased risk for concomitant heart attack. Just by vitals, at minimum, he meets SIRS criteria plus whatever this inciting issue is. In terms of his blood pressure issues, which, his blood pressure was borderline, what do we do? Do we give him fluids? How much? Which kind? Pressors? Which one? When? Steroids? Do we do low-dose steroids? High-dose steroids? Do we do any steroids? What about glucose control? Or what kind of goals for sugar levels are we looking at? What about empiric antibiotics? And what type of workup do we expect to do? Remembering that the pertinent pauses, again, he was febrile, tachycardic, mildly tachypneic, blood pressure borderline at best. So talk about nomenclature. I got asked at a recent lecture about septicemia. To be honest, this is verbiage from prior to 1992. I wouldn't recommend using this. In terms of SIRS, this is systemic inflammatory response. 2 or more of these criteria, whether it's being febrile or actually having a temperature less than 36 degrees, a heart rate more than 90, respiration rate more than 20, an arterial carbon dioxide less than 20 millimeters of mercury, elevated white count more than 12,000 or less than 4,000. Sepsis, this is essentially a stepwise algorithm, is SIRS plus an organism. I have SIRS plus a bacteremia or SIRS plus a source. Severe sepsis, and then these are also different clinical criteria for sepsis, severe sepsis and septic shock from the New England Journal of Medicine article. Severe sepsis is sepsis plus end organ damage, like sepsis plus AKI or acute respiratory insufficiency. Septic shock is sepsis plus the need for pressors despite adequate fluid resuscitation. This was a nice graphic via Medscape that showed these overlapping Venn diagram, essentially sepsis in the center, where you have SIRS that can come from many different things, whether it be trauma, burns, or pancreatitis, or infection, but that also infections can come in many flavors where they reach sepsis, but not necessarily SIRS criteria. At least not easily, because for example, fungal infections don't necessarily present with as elevated vital signs as one would expect. In terms of severe sepsis, the annual incidence in adults is of the up to 300 cases per 100,000 persons. Fundamentals with severe sepsis is to recognize early, control the source of infection, the timely administration of antibiotics, and resuscitation with fluids and or pressors. Severe sepsis, we know, has a mortality rate from 10 to 30%. Unfortunately, septic shock is up to 50% mortality. Late sequelae from sepsis, you have increased risk for death in the following months to years, and that there is a suggested acceleration of neurocognitive decline. So in terms of when we look at a patient, you want to know, where is my patient coming from? Is the patient coming from the community? Is the patient coming from a healthcare type of situation, different risk stratification of your organisms? In terms of pneumonia, if you look at all cause in terms of severe sepsis and septic shock, about 50% of them have pneumonia. Some have intra-abdominal sources and others have urinary sources of infection. What about workup? You're going to do cultures. Blood cultures are positive in up to a third of patients. Most frequent gram-positives are your Staph aureus and Strep pneumoniae. Most frequent gram-negatives, E. coli, Kleb, and Pseudomonas. With toxins, this is a lot of what is driving the change in vital signs and how the patient clinically looks. In gram-negative bacteremia, the lipopolysaccharide LPS is driving this inflammation. In gram-positive bacteremia, you have your MAMPs, you have LPA and MDP. In terms of superantigens, not to be underestimated is the staphylococcal toxic shock syndrome, as well as streptococcal pyrogenic exotoxin. This is a nice graphic talking about how we have our different gram-positive, gram-negative, and how we recognize them, how then we create inflammation, and then ultimately how we create pro-inflammatory reactions with NF-kappa beta. Risk factors for severe sepsis: issues related to the infection or from the patient. Is the patient immunosuppressed, asplenic, common variable immunodeficiency? If your status poses solid organ transplant or a hemopoietic stem cell transplant patient and on immunosuppression, do you have a primary illness that is overall immunosuppressing, like uncontrolled diabetes? Issues related to the risk of damage to the patient. This can be related to age, sex, race, or ethnic composition related to the organism. What about presentation of a patient with sepsis? You can have the lungs can have issues that would present as ARDS. The thyroid can appear as sick euthyroid when you pull your thyroid studies. In the brain, you can have altered mental status or acute delirium. You can also, after being in the ICU for a long time, present with critical illness, polyneuropathy, and myopathy. In terms of GI, you can have paralytic ileus, and in heme, you can present with DIC. Pathophysiology of sepsis. This was a nice graphic talking about, uncontrolled infection or major trauma, circulatory shock, tissue necrosis, apoptosis, that you have these triggers. After you have your insult, you have complex systems that are working together. You create all the biomarkers that there are ongoing tests trying to measure, leading to inflammation in all organ systems. And then you can either have, as your ultimate result, effective source outcome, or you have ineffective source outcome. The Surviving Sepsis Campaign initially came out in 2004, got updated in 2008, and the latest update was 2012 that was published in 2013. This is an international multidisciplinary consensus. They, using the grade system, then went through all the data that was available up to that point. In terms of resuscitation, they recommended within 6 hours of recognition that you should get crystalloids plus or minus albumin to be set at approximately 30 mL per kg. This is a 1B indication. In terms of pressors, they recommend norepinephrine. It is recommended as the first to keep your MAP above 65. Epinephrine is choice number 2. You can consider steady state vasopressin at 0.03 units per minute. The butamine got very much downgraded to only if you had cardiac issues, and that if you were using steroids, this would be someone with pressor refractory hypotension usually, and it's at that drip dose of 200 milligrams per day of hydrocortisone. The goal hemoglobin was taken down to 7 to 9 grams per deciliter. From the infectious aspect of sepsis, they wanted blood cultures prior to antibiotics, ideally, especially peripheral and from each lumen of lines. Administer broad-spectrum antibiotics within 1 hour of diagnosis of sepsis. Empiric antibiotics shouldn't be continued for more than 3 to 5 days, meaning that your antimicrobial stewardship aspect of how you take care of septic patients comes up, and that you should either de-escalate or escalate based on your scenario. Consider the use of biomarkers such as procalcitonins in aiding in de-escalation. It's a relatively new field with a lot of data that has come out. In terms of respiratory support, the ongoing use of low tidal volume and minimal PEEP to decrease the risk for ARDS. Elevate the head of bed if possible. This is a 1B indication. And definitely to use protocol-specific approach for weaning trials from the vent, a 1A indication. In terms of general care, that there are protocol-specific approaches for blood glucoses less than 180, that we should administer DVT prophylaxis as well as stress ulcer prophylaxis, and that addressing goals of care, including treatment plans and end-of-life planning as appropriate. So going through some of these in more detail, in terms of the resuscitation within 6 hours of recognition, you want to keep your CVP above or around 8 millimeters of mercury, your SCVO2 of 70%. This means the superior vena cava oxygenation saturation rate. You want lactate normalization, so you're going to be doing serial lactic acid measurements, and a urine output of at least 0.5 mg per kg per hour. At the 7.5 years of Surviving Sepsis Campaign, there was an update that came out by Bacher et al. In 2015, and they felt that due to the Hawthorne effect, that performance metrics are changing and actually being met, which is fantastic. In 3 to 4 years, hospital compliance went up to 30% with the use of resuscitation bundles. Glucose monitoring and control became actually less critical. Antibiotic timing, though, continues to be important, especially when having septic shock. So there are queries about things that have been considered the norm in the past, but are they still currently correct? So in terms of low-dose steroids, the thought process was in critically ill persons, about 30% of us would be adrenally insufficient, so that if you were septic, perhaps you would have a higher rate of adrenal insufficiency. Looking at the Surviving Sepsis database, there were 218 sites between 2005 to 2010, and the number of patients that required pressors, 17,847. 50.4% also received low-dose steroids. The adjusted hospital mortality, though, was actually significantly higher if you got this low-dose steroids with an odds ratio of 1.18. Statistically significant. In terms of glucose monitoring, the protocolized manner for measuring and adjusting abnormal blood sugars was very important. They stated that if your blood sugars were consistently above 180 on 2 consecutive stabs, that you should start insulin. and that we would loosen a little bit our sugar control. The goal of blood sugar is less than or equal to 180, that we're no longer shooting for that less than or equal to 110. And that you should check your blood sugars every 1 to 2 hours until the levels are stable, and then blood sugars can be checked every 4 hours. Note, there can be definitely differences between point-of-care capillary tests and plasma glucose. In terms of feeding during sepsis, we recommend starting oral or enteral feedings within 48 hours of diagnosis of severe sepsis or septic shock. This is a 2C grade. You can consider low-dose feeding and then advance as able, and that the recommendation is for IV glucose and enteral nutrition much more so than TPN, and do not actually recommend specific immunomodulating supplementations in patients with severe sepsis. In terms of the acute respiratory distress syndrome, just a couple words about pathology, that this is a diffuse inflammatory process of both lungs. Exudates in the alveolar spaces have red blood cells, white blood cells, and proteinaceous debris. The predisposition is that you have SIRS or sepsis, but it can also be from intracranial hypertension, long bone fracture, and numerous other issues. How does it present? It often has tachypnea, progressive hypoxemia, that the infiltrates are more prominent, especially in the periphery. It tends to be acute. Your gas exchange drops, your PaO2 over FiO2 is less than 200, and the wedge pressure is also low. So we no longer use the acute lung injury phrase. There is now just grading of ARDS. Mild ARDS being a PaO2 over FiO2 of less than or equal to 300. Moderate is less than or equal to 200. And then severe ARDS is if your PaO2 over FiO2 is less than or equal to 100. So in terms of sepsis-induced ARDS, you want to keep your tidal volume goal of 6 milliliters per kg of predicted body weight is a 1A indication. Plateau pressures in a passively inflated lung should be also lower, less than or equal to 30 centimeters of water. Utilizing both above guidelines improved all-cause mortality by 9% per the paper ARDS of Berlin definition in 2012. A particular mode of ventilation, note, is not recommended over another, though. Interventions to decrease the risk for VAP or ventilatory associated pneumonia. We should keep the heads of our patients' beds elevated between 30 and 45 degrees to limit aspiration risk and therefore decreasing the risk for VAP. Enteral feedings, note, do increase the risk of VAP, but it's more if you keep your patients supine. You can have VAP in 50% of those patients. If you keep the patient at a semi-recumbent position, then the VAP is only in 9% of those patients. What about PA catheters? I have interesting memories of PA catheters when I was in training, and they were most of them not very nice. That they're difficult to place, they're difficult to keep working appropriately, and to understand the information that they give you. And that was the bottom line now, is that pulmonary artery catheters can give information, but it's interpreted poorly, and that even more importantly, that there was a lack of improved patient outcomes with their use. So the bottom line is, do not use PA catheters for patients with sepsis-induced ARDS, and it came out with a 1A indication. Kidney dysfunction and sepsis. Overall, there is a high incidence of AKI, usually from acute tubular necrosis. Severe sepsis plus AKI is an incidence of 23%. Septic shock plus AKI is an incidence of 51%. It makes it difficult, unfortunately, when you have AKI to meet the benchmark of how much urination you want your patient to have for appropriate fluid status if the patient actually already has oliguria. What about non-infectious causes of fevers in the ICU, which unfortunately is more common than we would like to see. There's often drug-related fever. It can be a hypersensitivity reaction as part of the continuum of fever to life-threatening reaction. You look at the drug as well as the delivery system. What else is in the bag that could give fever? Here, your median to fever is 5 to 8 days. Main classes of drugs causing drug fever: antimicrobials, especially beta-lactams, anticonvulsants like phenytoin, antiarrhythmics, as well as antihypertensives. In terms of antimicrobials, just a few words about beta-lactams like meropenem, piptazo, and ticarclav. There was a lot of data in like 2012, 2013, looking at the comparison of intermittent dosing versus continuous infusion, which would require a dedicated line for giving the antibiotic all the time for 24 hours. And the study endpoints, it actually looked here at the bottom, ICU survival versus hospital survival, that there was no significant statistical significance between the two groups, whether or not you gave continuous infusion versus intermittent dosing. And thus, if line access is an issue, then you could definitely just use intermittent dosing without any loss to your patient. What about biomarkers like procalcitonin? Well, first of all, what is it? It's a 116 amino acid peptide involved as a precursor in calcium homeostasis. It was studied as a marker to differentiate sepsis from other non-infectious causes of SIRS. Now, if you look at all comers, ICU, surgery, emergency room, the data really couldn't tell the difference between sepsis and non-infectious SIRS. The sensitivity and specificity was low at 71%. But from a stewardship perspective, actually it has been shown to aid in de-escalation without an increase in mortality. The data is much better for medicine patients than related to surgical patients, that perhaps there's too high of a rate of false positives in surgery patients due to the quote-unquote stress of going for surgery or trauma. So this was snagged from the CID article, but discussing how different universities have different protocols for de-escalation. If it's low, if it's not low, what would you consider at that junction in time? There's also been systematic reviews of 5 randomized controlled trials concentrating on ICU patients and procalcitonin-driven antibiotic management. That procalcitonin-driven therapy was associated with 2 to 3 day reduction in antimicrobial use, and again, no overall effect on mortality, because that's always a concern. If you decrease the antibiotics now or de-escalate the antimicrobials now, that my patient will die in the future. But all of this more recent data in 2011 compared to the original paper in 2007 is showing that there is no increase in mortality. Limitations of procalcitonin, like all tests, that there are limitations, is the risk for false positives, so would not recommend to use it in newborns. Major stress situations like trauma, surgery, or cardiac issues like cardiac shock. Fluid overload in AKI or even chronic renal failure. Paraneoplastic syndromes like medullary thyroid or small cell lung cancer. If you're using cytokine stimulator use, OKT3, ATG, IL-2, alemtuzumab, these are drugs that often we use in different immunosuppressive plans for bone marrow transplant patients or even organ transplant. Procalcitonin is also not recommended for use in malaria and certain fungal infections. There are other diagnostics that have come to the forefront utilized at my facility, which is a tertiary care cancer facility, like the FilmArray, where the BioFire is the instrument, and then you take the pouch into the loading station, you inject the hydration solution, inject the sample, and then run the sample. And then here you have lysis, you have purification, PCR1, PCR2, water injection port. There's obviously multiple dilutions, trying to figure out what's going to come up from your blood BCID panel. And it has two 27 targets that is measuring. So what would happen in real life is your blood culture would have the bell that is positive. They take out a little bit, they do the gram stain, they release that to the computer system, so you know, for example, gram-positive cocci clusters. And then they run this, and in about an hour, you have, whether it is, for example, Staph aureus or non-Staph aureus, and then you can go from there. It still takes an additional 48 more hours to grow it on the plate to get you your full sensitivity, but at least here, within an hour of a blood culture being positive, we have a good chance of having an ID of what exactly we're dealing with. And this is the full 27 points. You can see though on the far right with antibiotic resistance, actually 3 of those points are looking for resistance mechanisms, whether it be the MEC-A, the VAN-A-B, or the KPC. There's actually other FilmArrays that we often use at my facility. The same machine, we're able to also run the respiratory panel that it has a number of different viruses. We also have now bacteria with the Bordetella pertussis, Chlamydophila pneumoniae, and Mycoplasma pneumoniae. This is stuff that is being ongoing work is for the GI panel that potentially will give you your answer faster, especially with the Campylobacter, bugs that ordinarily you would have to grow on the stool culture like Salmonella or Yersinia, and then of course the diarrhea related E. coli. That would be very neat to have the information in a rapid manner. The parasites are also there instead of having to send for OMP, and each of these items to be done separately. Here's a single panel that is still undergoing quality control work to see if we're a candidate to have it at my facility. And the same thing with viruses, that whereas a lot of these viruses are send outs in a facility like mine, here it's all in one FilmArray. Other specialized ID tests that are out on the market is this big list you can see from the 2008 article. What oftentimes we see used a lot even in community hospitals is the ability to get a Legionella urine antigen. Note though, is definitely only for serotype 1, and therefore if you have a different serotype of Legionella, your urine antigen will still be negative, but it would grow, say, on a from a bronch on an actual plate. The other one that we often use is the nucleic acid testing for either MAI, MAC, or MT Mycobacterium species in general. Comparing 28-day and 90-day mortality in solid organ transplant compared to non-transplant patients. This is matched 1 to 2 by age, sex, location, and hospital. This is definitely blood culture proven sepsis. They had a bug in hand. They wanted to see, will the organ transplant patients die faster or not? And they had 123 cases compared to 246 controls. The majority, as is in the community, were kidney transplants followed by liver transplants, KP, small bowel liver, heart, lung, and multivisceral. What they did show is, that the univariable, these were the different factors they looked at, but once they finally did the multivariate, that these are the only ones that made a difference: the presence of comorbidities, their SOFA score based on this paper, the presence of a nosocomial infection, the white cow, and the appropriate initial antibiotic regimen. And there was only actually the last 3 that ended up being statistically significant. Then if you looked at crude versus using a propensity score, at first glance the crude mortality rate is not that different between transplant and non-transplant, 8.1 versus 8.9. But then when they did the propensity score, here we have a mortality with sepsis of 14.6% compared to 9.8% in non-transplant recipients. So going back to the case that I created for this presentation, in terms of our patient's BP issues, what do we do? How do we treat him? What workup do we have to do for him? So we give him fluids, we attempt to stabilize him, we get labs, CBC with diff, CMP, the respiratory panel, at minimum a portable chest x-ray. Since he's coming from the community, we would do our urine antigens looking for community-acquired pneumonia. The chest x-ray is consistent with pneumonia, so we start him on antibiotics for CAP in an admitted patient. So in terms of CAP, there is a breakdown of outpatient therapy like azithromycin, levofloxacin, amoxiclav plus azithro, doxy depending on your allergy breakdown, ceftonir plus azithro. If your patient is admitted, we're talking about more like ceftriaxone plus azithro. You can still consider levo or moxy. If someone is very sick, cefepime plus azithro, or again depending on allergies, ertapenem plus azithromycin, to make sure you're covering both your atypicals and strep. A different type of case in terms of sepsis, a 49-year-old female with past medical significant for metastatic breast cancer with known mets to brain and bone, presented with fevers, chills, weakness, and leg discomfort 2 days post finishing her most recent Taxol regimen. Her physical exam is as shown. She has a fever of 102.3, heart rate 120s, blood pressure 110s over 60s. In terms of pertinent issues, she had chemotherapy-induced neutropenia day 3. It was less than 14 days. Vital signs in terms of blood pressure were within normal limits. Her leg issues were seen on the physical exam, where she had this big ballooning area over her lower leg along the back of her calf and her medial knee. She denies any visit to the ocean or fresh shellfish ingestion, trying to risk stratify for Vibrio. No history of liver dysfunction. The microbiology showed gram-negative rods. The concern was for necrotizing fasciitis, especially in a neutropenia patient with a limb that looked like it did. In terms of workup, we sent for CPK. In terms of imaging, we did plain films to rule out gas as fast as possible, and with the consideration of a follow-up MRI as needed, and that surgery was consulted for possible debridements if so needed. From our side, we made sure that we had appropriately broad antibiotics, considering she's neutropenic, plus having possible neck thrash, so that's going to be piptazo or meropenem. The consideration was given for clindamycin due to the ability for toxin binding, as well as a consideration for IVIG. There are specific indications, usually hospital dependent. This particular patient did not receive any IVIG. In terms of our case, there was no subcutaneous gas on imaging. Orthopedic oncology just felt it was consistent with severe cellulitis, considering the imaging. And the family, due to the patient's poor quality of life, decided that she would become comfort measures only. She never went to surgery. She actually had her antibiotics discontinued and the patient passed away. In terms of necrotizing fasciitis, our organisms are a handful, being the group A strep, Staph aureus, Aeromonas, Hydrophila, Clostridium species, E. coli, Klebsiella pneumoniae. Treatment, repeated surgical debridement is the mainstay. Antimicrobials and plastic surgery, ultimately, if the patient survives, in order to fix the defect that remains behind. Other stigma of septic shock, you can see here you have peripheral dry gangrene because of vasoconstriction, often between the infection, as well as the use of high-dose vasopressors. And then unfortunately also on the hands. Again, talking about the tiered system for describing SIRS versus sepsis versus severe sepsis and septic shock. The future, hopefully we'll have a panel of biomarkers as described in the Reinhardt paper in 2012. A bioscore is a compilation or combination of multiple tests. The STREM1, the serum concentrations of soluble triggering receptor on myeloid cells 1, procalcitonin, as well as polymorphic nuclear CD64 index and flow cytometry. There's also Molotov and a number of different facilities, especially in Europe, where they have the flight of time mass spectrometry. It gives you your identification right away of your organism. And that is it.